Start the meeting now? Okay, let's start the meeting. I'm Andrea from the Clinical Surgical Oncology Editorial Office in the GMED. Thank you very much. I would like to take a few minutes to express my gratitude to all experts who participate in this webinar today, and also introduce the background of this academic conference. And GMED is the educational arm of Jianhui Health. We aim to solve the pain points in existing medical education and improve the awareness of medical progress among global healthcare professionals. And for Clinical Surgical Oncology, it is a journal that seeks innovative research and advancements in surgical oncology, and it also serves as a dynamic platform where breaking ideas in the surgical improvements are showcased. And today we are here holding the 5th ESSO-CSO academic seminar in 2025. We will focus on artificial intelligence in hepatobiliary and pancreatic tumor diagnosis and intraoperative decision-making. And we will initiate communication between statisticians and surgical oncologists, which is part of clinical research training course. Okay, let's start our first session now. And I would like to invite Dr. Dana and Dr. Rafa to continue introducing and moderating the following session. And thank you and welcome.
Thank you very much, Andrea. Thank you very much for. So first of all, I welcome everyone to this webinar and thank you very much for attending. We have a mixed platforms with through WeChat from our colleagues from China and Zoom from our European colleagues. So thank you very much, everyone, for being here. My name is Rafael Diaz. I'm a liver surgeon in Liverpool University Hospital in the United Kingdom. And with me moderating the session today, we have Dr. Shoronova from Newcastle, HPV surgeon, as well as Professor Jun Lee, that is a professor of surgery, very good friend of mine, with background training in Germany, the United Kingdom, and now chief of the Department of HPV in Shanghai. So we three will try to moderate these sessions with three key speakers. Before that, and a bit of, we would like to understand if I would like to share, if we could stop sharing those slides, Andrea, I will share quickly. That's great. Thank you. I will share this screen briefly with some key messages from us. I hope you can see. Can you see? Just a bit of thumb up. You can see the slides. Is why ESSO and who is the big umbrella that we are under today. So the European Society of Surgical Oncology is the big European group covering other smaller national societies of people looking after surgical oncology. It's a very nice, friendly, collaborative society that gives cover to many subspecialties and is incredibly interesting. Obviously, from talking with people from China, we need to say that this is not European limited, and we have members join from as far as South America, Africa, and all over the world. So we are always opening to other societies, and you are very welcome. There are many reasons why joining the society or partnering with us or being part of this bigger family, but we are definitely keen and focused in education, promoting core curriculum and developing of surgical oncology as a specialty across Europe and across the world. And obviously, you know, we have a very strict, rigid peer review process. This is our journal that is quite successful one where we take a significant part of it. And of course, on top of our yearly big congresses, that is multi-specialty and covering a wide range of specialties, but there is also translational, transversal themes where everybody is welcome and can take part. Of interest, for example, we have advanced courses in pancreatic cancer, in liver surgery, in peritoneal disease, in all the subspecialties. There will be big groups. So please, everybody feel welcome and encouraged to join ESSO and take part of it. That is the big umbrella covering that. So I shall stop sharing, and because you're not here to listen to me, and it is my absolute pleasure to give pass to our first speaker, that is Nikki Rashidishan, Professor Rashidishan, that is a HPV surgeon from the University of Kent, but also professor of computer-assisted surgery, and with a significant role leading on this on the ORC Academy, that you know is one of the greatest academies that we have in Europe. So, Nikki, thank you very much. We will not take more time from you. As a generic comment, we were thinking that in order to stick to time, we will allow all the speakers 15 minutes for the presentation, hoping that we can have then a good 10 minutes for discussion at the end of the 3 presentations. We have suggested that for those people from Europe logging through Zoom, the Zoom platform, they can post this question through the chat that we have open here. From our Chinese colleagues logging through WeChat, you're very welcome to do the same, and hopefully Andrea can have a bit of a link between the two of us. So, Nikki, thank you very much, and all yours.
Thank you so much, Rafa, for the kind introduction, and thank you for the kind invitation to be part of this webinar. I think if you stop sharing, then I can share my slides, please. Perfect. Thank you so much. Actually, today I'm going to talk about the role of AI in a preoperative imaging interpretation for HPV malignancy. These are my disclosure. I'm a director of research at ORC Academy, and I'm a consultant and advisory board for several medtech companies. But this is unrelated to this talk, and I have no conflict of interest. These are the topics that I will be briefly talking about today. Actually, before we get into the role of the AI in preoperative imaging for HPV malignancy, I would like to start with the foundation, what is called surgical data science, which is actually relatively a new and a rapid growing field that brings together surgery, computer science, engineering, and data science with the goal to make surgery a bit safer, smarter, and hopefully personalized. So surgical data science is not only about artificial intelligence, but AI is one of the tools within very broad spectrum that we can use for actually analyzing our data. Of course, today I want to focus on AI in imaging, but we need to think about that AI is basically transforming the way that we are practicing surgery already has transformed a lot, and we are hoping that in future we can use it in the clinical practice. So about the talk of today, we and all the HBB surgeons in the call would agree that despite the decades of technological progress that we have here, seeing still interpreting the HBB oncology images is very much subjective and a human task. And it means that if two surgeons or two radiologists looking at the same scan, we can always draw a slightly different conclusion that can change the plan of the patient, for example, from getting a neoadjuvant therapy to surgery or vice versa. And that's still very common, I would say, all over the world. The challenges that I could think of for HBB, while it's worldwide, of course, a lot of other specialties have the same challenges, but specifically to our field, we can think about the diagnosis or detecting the tumor. Still, we do have sometimes, a lot of time, problem in identifying some kind of tumor or distinguishing between the benign and the malignant lesion. We have the issue of local resectability that we want to define. We want to have a better and more objective way of how we can assess the resectability of the tumor. And then we have the problems of staging, finding the small metastases, and in the end, what it goes to the liver surgery mostly is the functional assessment that we do need. And I think we are still far from being perfect in that areas. So these are the areas that we hope that in future we can get some help from AI. And in this talk, I will try to briefly show the areas. Of course, most of them at the moment are research areas, but if we can see the possibilities that AI can bring with us, with itself for us, so maybe we can kind of contribute and accelerate those research in this field. So over the past decade, we have actually evolved from having the 2D images going to the 3D modalities, and those 3D modalities are mostly being used also for assessing resectability, for functional assessment, and we are even bringing them in virtual reality and also to the OR as augmented reality. I believe my colleagues in this call, because I was looking at the topics that are being discussed, will cover a lot about augmented reality and more modern technology that is being used. So I try to specifically look into the 2D images that we still are using in our daily practice and see how we can use AI for interpretation of those 2D images. I want to actually basically, from my little insight about how the AI technology works, divide it more in the structural way, that how and from which AI technique we can use for what. Computer vision is actually one of the branches of artificial intelligence that has the most application in surgery. Because we can have basically computer to understand the visual information, much like our human eyes can do it. And in medicine means that we want to teach algorithms to see and analyze medical images such as CT scan and MRI. And this system can basically detect and measure some measurements that are difficult for us as a human to do. And with that, we can benefit from having more objective look at our imaging. And why is it's important? Because computer vision can help us to pick up a small or very little pixel level details that a human eye might not see, but the computer can see it in more details. And it can also help to reduce time to actually bring more standardization in the way that we look at the images. So this is a very common example in research that a lot of groups are working on it. This is a computer vision model called a CNN, or convolutional neural network. And it can look at the CT scan images and try to differentiate the different type of a type tissue. How it works, basically it compares the computer compares what it see on the CT scan with the actual histology that we have from the pathology. So the computer being trained on the retrospective data of the patient who already got the surgery, and we do have the histology there, and
Nikki, sorry, am I the only one not hearing Nikki? If she can rejoin. Yeah, we could hear you well.
Yes.
Everything was working well.
Perfect. So I will try to continue. I don't know what happens. Hopefully it was just once in time. And I will go a bit faster for the time that we lost. Doesn't work, those.
So don't worry, we have time, so it should be fine.
I just get some part of the problem done. Perfect. So I was talking about the computer vision model that we can develop based on the pathology. And actually, this is a very good example, a work done by the group of San Francisco, looking into the SMA margin for a Ripple procedure. And they have developed an algorithm that can predict the superior mesenteric artery margin status using computer vision techniques. And as you can see, the algorithm in this data set has outperformed the radiologists and surgeons. Another example of what we can use AI for is radiomics and machine learning. Actually, radiomics is something that we hear a lot about it. And in essence, radiomics means turning image into the data. It means that we extract the thousands or millions of quantitative features from medical images. And then we try to describe all like shape, texture, and also like the ideas like intensity and this kind of stuff in a numeric data and train the model based on those data. And this is actually, if you think about it, as a surgeon or as a radiologist, when we are looking at the image, we are, well, maybe radiologists are also looking at texture and intensity, but these are things that we are basically missing in our interpretation. But we can have a computer doing that. And this is actually a great example of such a study who has worked on radiomics in liver cancer diagnosis. And you can see in this study, radiomics features are extracted from the preoperative CT scan of, I don't know, I think more than 340 HCC patient cases. And they have tried to predict the likelihood of macrovascular invasion. A model combined feature that they have extracted could reach to the very good predictive value to show the macrovascular invasion of the HCC. So in essence, now using this approach, we are basically turning the routine CT scan to a non-invasive tool for biological insight, which is something that hopefully in future we can use it more in our practice. Next thing that we can discuss is about multimodal AI and why it's very important, because multimodal AI help us to go beyond just having imaging, because we are all clinicians and we know that image alone doesn't tell us all the part of the story, but multimodal AI tries to integrate imaging data with clinical data, lab data, and all the genomic information and many others, and this actually mirror the way that we work as a multidisciplinary team to make decisions and to make like our clinical judgment. And this multimodal AI is based on this concept that if we give more dimension of the data, we can get more insight from that. An example for this would be, for example, if we want to differentiate a PDAC from a mass-forming pancreatitis, here they have developed a multimodal radiomics clinical model that can achieve an accuracy comparable to the EUS-FNA. But as you can imagine, it's a very non-invasive procedure. You can only include clinical data as well as radiomics data and get something as accurate as a ground truth, which is quite promising. Next thing that is, I think, hopefully will be more promising in future, because those studies that we just look at them briefly and examples that we reviewed are mostly coming with the small data set, and generalizability of this data set to a broader and to the centers outside this is very difficult. If we want to have a machine learning model or AI model that can help for a better understanding, we need to have a huge amount of data. And of course, when we need a huge amount of data, annotation of those data and transferring those images to the data would be a very challenging from the scientific point of view, because we deal with a huge amount of data. But nowadays, we do have these techniques of computer, of AI and machine learning that are actually also very much in a high speed are progressing, which is called self-supervised and foundation models. And what that means is that these models learn from a vast amount of unlabeled data. So as a researcher, we don't need to classify them. We just pre-train the model on the data itself without any assumption, any interfere from the researcher. And then when we did this training based on this huge amount of data, then we can introduce a subset of data that are specific to a specific tumor or something else, and then will be those small amount of data being working on the pre-trained data that can give us a final diagnosis tool, which is very much usable in the real life data. And this is actually in HPB oncology is very important, because the amount of the annotated data that we have is very limited. and sometimes we are also dealing with some rare tumors. And these foundation models here have huge potential. But as I mentioned, these models comes with several challenges. They require a huge amount of diverse data set. There is a sophisticated pre-processing of the data, and it needs to be carefully validated. And there is also reliability, interpretability, that clinical validation that I will try to also mention, because as much as I am fascinated with AI research, we also must know that to having them and using them as a clinical decision tool is still a big challenge. So I would like to also talk about a bit AI reliability, because I think it's also very important. We all hear about the potential that AI can bring, but it's also very important to be mindful about what can go wrong when we are relying on AI. So these are the concepts that probably we have heard a lot about it, but I want to review them together, because as much as the enthusiasm that I have personally as a researcher, as a surgeon for AI, I will always try to keep in mind what is the limitation and where we have to be very careful when we are advocating for using AI. The most important concept is that AI talks about probability, and probability doesn't mean certainty. So we predict things and we are not guaranteeing anything, and every output still requires to have the interpretation of us as a clinician and as a surgeon. Then next is that
apologize,
also...
Nikki, can I interrupt and give you one more minute, please?
Sure.
Is just to keep it tight and we don't jump into the second webinar, please. Sorry.
Sure. Actually, I think this is actually my final slide, so I will just try to be short on this. We do have a concept of statistical significance that is not clinically relevant, has been talked about for many years, but it's also the same thing for AI. Specifically, we are dealing with much more of a sophisticated data set. And it's also the training data set that is always not the real life data set. And these are the things that we should not forget about when we are talking. And so to just go to my conclusion and respect the time, AI is basically transforming the preoperative imaging in HPB surgery from detection to decision support. And computer vision, radiomics, and multimodal models has the possibility to enhance the diagnosis. The future should be more of a self-supervised and foundation models to reduce the dependence on the label data. And we should be mindful when we are using it, as AI gives only probability, not certainty. And in future, I hope that we can integrate these AI tools into our multidisciplinary workflow and entities, and we can hopefully expand the multidisciplinary data set for developing it. And if I think we are going to take the questions at the end, but if anyone interested in surgical AI, I would like to invite you all to our Surgical AI Congress that every year being organized at Orsi Academy, well, in Ghent, not at Orsi Academy, but by Orsi Academy in February. And of course, everyone welcome to join.
Nikki, thank you so much. We can just send the virtual applause. Thank you very much, really interesting. And sorry, we had to be strict to the time. As you said, we are welcoming people to post questions on Zoom or via WeChat that we translate. And yes, if the last, whatever is left, 5-10 minutes, we can go through those questions. Thank you very much.
So it is my great pleasure to invite the second speaker, which is Dr. Gregor Stavru, who is a hepatobiliary and pancreatic surgeon and also the chief of the Department of Surgery at the Clinicum Saarbrücken. He has a strong interest in the AI, and he will give us his insight into the pancreatic AI device. Many thanks, Dr. Stavru, for joining us today.
Thank you all for letting me talk about a little bit about our project. Can I get the now I can, so I can try and share this. And does that work?
It looks well.
Can you see the presentation? Yeah,
we can see the slides. Yeah, thank you.
Okay. So what I'm going to talk about is I mean, Nikki has always have given a perfect stage for that. So I can skip some of the things, but this is a little bit more practical idea out of that we try to come up with. To my view is obviously, as a surgeon, I want to have help and not have help in 10 years, but ideally next week. So this is what we're trying to do here. So I'll skip this because Nikki has perfectly set the stage for that. It's just something that can really be useful, I think, especially in training. And the reason that also Nikki has mentioned, but the reason why not much is done yet is those organ deformations in the open and also in the laparoscopic or robotic field. So this makes any kind of navigation much more difficult, because to calculate those organ deformations is really difficult. And we've tried this before with image overlay and navigation techniques in liver surgery, and it's always been very difficult for liver. So this is the reason we turned towards the pancreas. There's been some good publications, mainly from Asia, trying to come up with first ideas how to cover the augmented reality operations in pancreatic surgery. So if you look at those publications and you look at the systems that were developed, it was usually something encountering a cognitive alignment process, and so very complicated and not very useful in terms of it was not continuous usage because the hands are occupied with these things. So this is something that is not very easy to use. So we wanted to create something this is even more helpful. And what we came up with is a solution that is not my solution. It's a consortium. It's partners, and we have partnered with the DFKI, which is the German Research Center for Artificial Intelligence, with many bright researchers and computer scientists. And the other partner is MEVIS, which is a system for 3D reconstruction, actually used for liver surgery, but also being able to reconstruct, obviously, the pancreatic organ into a 3D model. And I've been using this for over 20 years, and it's a very fine reconstruction tool. So combining all this together with the now available HoloLenses, we were aiming to build a system that can actually help us during the operation and not disturb any kind of operation. So what we did, and that's, to me, something which is a new process, is that we had the chance to talk with a computer scientist from the beginning. So it's not like a company comes to the surgeon and say, yeah, we have developed this, can you use it? So this was actually something we set together, said, what would I like to have? What can you program? What can you do? So we had interviews, we had design sessions of the system, and we had a preliminary testing of the system. So the idea was to get the image, the 3D model, into the HoloLens and onto the actual CTUs, also requiring a kind of navigation of the model into the abdomen. And through a lot of refinements and testings, we managed to come up with this system to a stage where we could actually use it in the operation room. So I'll show you a bit about that later. So the first case we used, it was a kind of surgically speaking critical case. It was an Appleby operation, which is a very special kind of operation where you also require to save some of the vessels, otherwise you're getting into trouble, or the patient gets into trouble. So this patient had previous interventional closure of the hepatic artery, which because the celiac trunk needed to be resected, and then we were using our system to create the 3D model. And this is just the model you can use for preoperative planning. That's nothing new, really, but this is also obviously always part of this model, that you can sit down at your desk and have like a preoperative session to look where's going to be the difficult part. And here you can see in green, you can see the tumor, and you can see the vessels at risk, and you can see basically where you have to cut and what you have to do. And then we came, especially with this case, we came up to the next question: how can such a system improve? And we are always working on improving this. And one of the findings was that if we can use an agentic AI that can sort of streamline this process and give us, from learning from data, give us ideas of dangerous moments, then this could help. And this is on another example. I'll show you what this agentic AI can do.
Yes. Can you show me the infiltrated vessel? The common hepatic artery, splenic artery, gastric artery, and splenic vein are either infiltrated or have a margin of less than 1 millimeter.
So this is a great help, and you don't even if you think as a surgeon on your imaging this is resectable, then this agentic AI can warn you there's going to be a problem. So you can develop a strategy to take care of this. But it gets even better, this is also in pancreatic surgery, one of the critical things is if there's a aberrant arterial anatomy, this can cause you, or this can get you into trouble. So this is something that the AI can cover as well.
Yes. Is there any vascular anomaly? Vascular anomaly was detected. 2 separate branch arteries appear to supply the liver, whereas normally a single artery divides into 2 branches.
So this is something which is really important. If you do a pancreatic head resection, you have this variation. You have to be very careful, and this could actually cause also a problem in your resection margin. So it's always good to know this. Obviously, we can see this in the pictures, but it's much easier if there is help, and it's also for junior doctors much easier to see this. So the next thing is, how can we transfer this into the OR? And I've had a lot of experiences with navigation issues in liver surgery, and we have been trying for years and years to get this thing done. And what we could manage with these HoloLenses and QR codes is sort of an ongoing registration process through the HoloLens. So with fixed markers, with these QR codes, the system automatically adjusts itself and registers the plan to the CETUS. And this is very, very helpful because you can actually really see what you're doing. So we have an overlay in the HoloLens. And this is just the setup of the OR. Don't get confused. This is for some reason with HoloLens, it doesn't put it on the monitor. In my HoloLens, I have a perfect overlay, and so that you can see that, and believe me, this is the CETUS of this Appleby operation. And what you can see is here I identified the celiac trunk and the common hepatic artery, which was closed already, but I have to watch out for the gastroduodenal artery. So if you see it like this, and this is the view I had, a superimposed image being correct, you can imagine that the stress of the operation is enough. So it's much easier. I call this coloring for numbers kind of thing. So also from a perspective of education for juniors, this is a very, very great idea. This is another case. It was an easy case, but nevertheless, with a tumor coming very close to important vascular structures. So in your overlay mode, this is quite becomes much easier to operate. So we also obviously evaluated the system on a Likert scale, and actually for vascular preparation and the resection phase, it was really good. And obviously, the more mobilization and you do, the more shifting of organs you have, and the less accuracy for the system. But for the critical phase, it was very, very good. And then we tried to look, did it make any difference on our outcomes? And actually, we compared it in a matched pair analysis to other operations, and we found that even though in this group where we used the system were more complex operations with vascular resections, that we found that the results in the ARROS group, which is here, were actually quite better. Okay, it's not big data, it's not big numbers, but the tendency towards a better outcome was there. And we could also see this even in hospitalization for more complex operations. So in conclusion, it has enhanced operative planning, safety, precision, and also for tumor-free resection margins. And I was really happy with the superior outcomes. I think the biggest field for this is it's an exceptional educational resource, preoperatively and also intraoperatively. And of course, there's still the problem of accuracy loss once you get into much deformation. So what about the future? And also, Nikki has talked about these data collections, which are most important for that. And I'll give you an example for that, because the ideal idea is you have a lot of pre-operative data, and you have sort of a model that you can create from intraoperative videos and intraoperative data, and get this into your registration and tracking model. So for this, you need data. And we are lacking this data. So one problem is, of course, we need to have an interdisciplinary research with the computer scientists, because we can't do this as surgeons. But we have to be in the driver's seat to tell them what exactly we need. There is these ethical and bureaucratic barriers. I'm not going to go into that, and obviously insufficient funding for this kind of research. But the biggest problem is the lack of comprehensive perioperative data, and that is the challenge for the near future. And to make the point, if you look at this, what generative AI can do, if you prompt the AI and say, can you create a video of a golden retriever running with his friend, a kangaroo, in the farm, you get like a Hollywood kind of movie. If you say, can you create a video of a surgeon performing surgery, you get something out of a 70s comedy kind of thing. So this has nothing to do with it, really. So to take this even further, if you say, can you create a video of pancreatic surgery with an AI overlay? Well, I mean, I'm not an orthopod, but I'm quite sure this is somewhere in the muscle. It's definitely not the pancreas. That much is for sure. And if you even ask for anatomy, then you get some strange things that have nothing to do with real life. And this is actually also an example of what Nikki was saying about that data is not always accuracy. So the only reason this doesn't work is that there is no data available. So we need to come up with these data sets to train AIs, and then we can improve. That's so far what I wanted to talk about, and I'm happy if you're interested in collaborating and get this thing together. We're always happy to share what we have and what we can do, and get forward together. Thank you.
Many thanks, Dr. Stavro. This was very exciting. I understand there is still quite some way to go, but actually now we have things that haven't been possible quite some years ago. So many thanks for sharing your experience with us. So we are moving to the next speaker, who is Wen-Yang Hung from Leicester. So he is the member of the Association of Upper GI Surgeons of the Great Britain and Ireland, and also the lab manager focused on islets and organ perfusion at the Department of HPV at the University Hospitals of Leicester. So we would very much like your insights on the machine learning and the AI models when it comes to early diagnosis of pancreatic cancer. Thank you very much for joining us today.
Many thanks, Dana, for the introduction. And I just try to share my slide first. And sure. So it's very nice. Nikki has introduced the AI in radiomics, which actually help with all the basically for my topic follow up with scan. And Gregor has also basically talking about intraoperative navigation with errors, which if we can actually pick up the early diagnosis of pancreatic cancer, so surgery certainly would be the curative the approach from our side. So I think there's more and more using an AI model to apply the early diagnosis of pancreatic cancer. So this is the area I try to actually introduce and then show you my result as well. And I have no financial relationship to disclose. So we know the pancreatic cancer is basically survival rate in 5 years is very low, and we know it's increasing globally. And it's also called silent killer because basically the patient doesn't really have any symptoms. So when the patient come to actually to the GP general practitioner in UK, basically you have a very difficult to find out what to approach because ultrasound isn't really a model to actually pick up any lesion in the pancreas. So certainly there's quite a lot of improving therapy, immuno, chemo, all that for the treatment, but certainly most of the patients still inoperable, then basically it's into the untreatable. How it's difficult is because there's asymptomatic. And this is the reason we try to find what will be the best way to actually find the early diagnosis. And as you know, the resectable pancreatic cancer only 10 to 15%. And then you got border, then you got metastatic in resector afterwards. So there's a window of opportunity. There's a lot of paper has been published, and how can we actually pick up early? There's many methods which I will actually explain later. So it's been we got to be able to pick up within the first 2-3 years. Seems there's an opportunity window we can actually identify. But regarding to the patient selection, this is actually a challenging area because certainly if it's not cost effective to the whole population of screen test. But if you move it to only the high risk, very high risk or high risk, then you only pick up probably between 10 to 20%. And a lot of patients still, there's no risk factor identified, and which is called sporadic diagnosis. So this is what the genetics and the cancer symptoms, which a syndrome, which they actually identify, which has a high risk. Then this is basically the risk for pancreatic cancer. So the next step is how we actually define and to select the population who we need screening. That's actually a challenging, but this is an area most of the country, they put the AI to use because all our data now, more and more patient health care is actually have electronic health record. So because of that, you got quite a lot of information. Then you can actually define what type of patient you need to have early screening. For instance, so this paper basically they publish basically that's what they say in this because you got the electronic health record, so they can actually look for 2-3 million of a population from their electronic health population record, pick up they only found only 10 to 20%, they actually had the risk factors. Then the other 10 to 20%, which basically have no risk factor at all. So this is the area how we actually be able to do some screening, who we're going to pick up. And that's what the Massachusetts Institute of Technology did mention, the selection, new hope for early pancreatic cancer intervention through the AI-based risk predictions. And this is a model which everybody try to build. It's from clinical data, from the symptoms, and how they present. And then we can select with the risk factor or no risk factor, and the age group, and the early onset diabetes. This is the area we can actually see, we can identify more and more on the high-risk patients. This is UK-based, basically GP practice. And this is good models which now approach the early detection pancreatic cancer from time series of primary care data. And because now we have a more and more electronic health record now, and the sample actually from the blood test, the scan, and all that, you can actually trace him back to few years earlier with their blood sample until they diagnose. And you can actually find some markers which has been changed during this period of changes. So that's what more and more are moving to this direction of a selection, patient selection have become more important beyond the AI. Then screening test, we know the ultrasound is not reliable at all. Then CT/MRI, it costs not effective to actually quite expensive. The endoscope ultrasound is quite specific, but certainly still also invasive as well. So how do we actually select patient to have a more invasive investigation? This is the area we actually looking for blood-based screening test. So there are a few trials, which one is based on the UK, and looking for the high-risk factors, then with the new cDNA type-based blood test to find the pancreatic cancer earlier. Then there is American Oregon Health and Science University looking for the nano sensor to measure the protein activity changes from the small sample there. The breast test, they're looking for the volatile organic compound in breast samples. So basically all this come up. The last one actually is already also on the clinical trial. It's urine test, looking for few protein biomarkers if they can detect early. They all look quite reliable and simple, and if they can actually pick up early, then you will be able to treat early and curative by surgery. Then from the test, certainly all these blood tests, urine and breast tests, eventually they will still need to rely on the CT/MRI scan or endoscopic ultrasound to actually more accurately identify the lesions. And more and more now moving to this AI is by the protein biomarker panels, but this is all quite expensive as well. But this is the way moving to, because there's no single molecular marker you're actually now using for the pancreatic cancer diagnosis, because we know it's quite heterogeneity over the pancreatic cancer. So this is also by the Mayo Clinic, which they use a CT scan. You can see the change over the body composition change then until they diagnose pancreatic cancer. So they do see the changes, but certainly this is actually has to look for series of image and the series over the time consuming to actually identify the changes. And this is what Nikki mentioned, all these the radiomics and with AI, how we identify the cancers. From my point of view, as you can see now, the key one is the patient selections. Then second thing is what is easy, reliable test to use, when to actually use, can be a screening. And this Sweden basically published this metabolomic for early pancreatic cancer, which they have a patient sample back few years before they develop cancer. You do see metabolomic changes. And that's the window can we actually pick up something easier as a screen like a urine dip and put something as a screening? Then this is quite popular area now, the gut micro-derived metabolomics in the pathogens progression to pancreatic cancers. And we do see more and more looking at the information, the gut information, and then react down to the metabolic changes. If we can measure something quick and reliable, and that's then the early pickup of the screening could be potentially curative. So now I'm moving on to my current project. Is because of all the information I mentioned. So we found that this machine is based in Japan, and it's probe-based mass spectrum ionization. And the test is quite simple. So basically, serum sample, you have 2 to 3 minutes from the sample to the analysis of mass spectrum, only take 2 to 3 minutes. That's fast, actually, analysis so far at the moment. So because of the machine we found, but you need a large cohort to actually see if you can see the difference using the machines. So that's how we have actually got a cohort from Taiwan with a large pancreatic cancer center in Taiwan University Hospital. And they do have a control from family history of pancreatic cancer without any MRI, MRCP to show any lesions in the pancreas as a control group. And we look this comparison. So because of the machine itself, it's a simple 2 to 3 minutes preparation, and you get serum sample to ionize into the 2 different modes, the positive and the negative mode. In this case, it's like this is actually mass spectrum result. You've got a spectrum of metabolomics changes as a patterns. And so we want to look at these patterns. Is any different between the control and the cancer? Then certainly there's quite a lot of process involvement to actually refine and to actually come up with be able to demonstrate reliable result. And because of you got a sample which you can ionize on the positive mode and the negative mode, so you got 2 group of the sample with mass spectrum ionization metabolic profiles. Then they identify, it's mainly the pattern. We certainly identify some peaks, but because this one is basically we look at the pattern. If you want to look at identify, confirm the peaks, we have to move to high-end mass spectrum. You can see from the data here, certainly we can actually divide the early stage 1, 2, and stage 3, 4, and the control group in very distinct pattern differences between these groups. So we can see even stage 1, 2, and stage 3, 4, metabolic change is completely different compared to controls. And we actually identify, we can get the specificity, sensitive and specific, or more than 90%. So we use remarkable, we can actually have an accuracy of more than 90%. If we combine the age and CA 19.9, then with the early diagnosis of a pancreatic duct stage, it will be 92.9 accuracy, and late stage, will be 93% accuracy. So which we actually published previously. And so the modality of using the machine to do something the same as like a urine test, breast test, everything you got to be fast, simple, but you need to be reliable as well. So there's a lot of work needed to continue. But the patient selection, if they monitor the changes, that's the next step of continue monitor if there are metabolic changes. You can pick up early the change, then you monitor patient, send for the scan. And we are hoping this will be able to be another modality of the method to actually to do as a screen test. It's like a barcode, which we can actually show here. Everybody metabolic change is like a barcode. What's the normal range? What's the abnormal range? This is the area we have to define. So hopefully we can move forward to show if there's any outbreak in the futures. Many thanks.
Thank you very, very much. Thank you for sticking to the time. I'm really grateful for that, and it's impressive. That graphic on the control group and it's impressive to see such a big difference. So congratulations on that. I didn't know that work, and I am impressed. We need to honor the questions that came up on the chat. We encourage people to ask, and there was a question, I guess, for Professor Stavro, saying that they usually use pancreatic protocol CT scan to plan the anatomy for pancreatic cancer. And the question is, do you think artificial intelligence really give accurate anatomy for planning surgery? Gregor, what do you think? Can you answer on that?
Well, I think basically, yes, I think it can. From all the, if I look at the MEVIS analysis, if you take the MEVIS software to analyze anatomy, it always also has a vascular AI included, and it works very well. So I'm not saying that you can, keeping in mind what Nikki has told us, I'm not saying that you should 100% always on the AI, but if the AI tells you there might be a vascular anatomy that is not your regular one, then you should really look for it critically. And I think that this is really manageable for AI and computer science to give us a very clear picture of the anatomy. If you have a good CT scan, but that's another story.
Exactly, that's another story. So, Junling, do you want to comment any remarks? We should close the session to honor the next webinar. Junling, anything to comment?
Right. I think it's a very three lectures are very nice, and we really the upfront knowledge of AI in HPB surgery. But all the things that in my mind is the one thing is the data. So we actually missing the data in all areas. We have JetGPT, we have other things, we have shared data in the internet, and I'm missing this one actually in our HPV surgery. Nowadays, actually, there's a lot of video. I think Da Vinci probably they collect most of the intra-abdominal anatomy data. I think they probably have most of the data that's available in the world to give us an idea about how the surgical development. I think this is related to Gregor's topic, because if you don't have the data, I think it's difficult to make an AI.
Yeah.
This is what I think. So this is my comments. Thank you.
Thank you. I think that's something we can all agree, isn't it? On the need of data, robust data, and how can it would be nice to have AI data collector. That is what we need. Anyway, so again, thank you very much, everyone. We should close the session. Sorry, we cannot give you a round of applause, but your work is exceptional, and please continue on that way. I shall leave then this back to Dana Shorova, and we'll pass to the second session. Thank you very much, everyone, for your collaboration, and congratulations. Thanks.
Thank you very much, Rafa. And we can move to the second session. It will be a slightly different aspect of research, and it will be focused mostly on the clinical research and the collaboration between the oncosurgeons and the biostatisticians. And it's my great pleasure to also be joined by another moderator, who is Van Meuk, who is a pancreatic surgeon from the Leiden University Medical Center in Netherlands. So without further ado, I would like to introduce our first speaker. And it's my great pleasure to invite to talk Professor Deborah Stocken. She works at the Leeds Institute of Clinical Trials Research and the Leeds University. And she has been involved in so many different research projects and trials. It's a real honor to hear her insights when it comes to bridging the gaps and how to effectively communicate within the teams, both in the surgical team and also the biostatisticians without the clinical research. Many thanks, Professor Stocken, for joining us today.
No problem. Thank you for the invite. Can you hear me okay? Yeah.
Yeah, we can hear you fine. Thank you.
I'm just going to try and share my slide. I'm not used to Zoom, sorry. So is that the right one? Can you see that?
Not yet.
Okay, that's not good. Let's try that one. That worked?
We can still see you, but not the slides at the moment.
Maybe you need to click. Yeah.
That working?
Yeah, that is perfect. Thank you.
Right. Okay. I've lost you, but never mind. Okay. Thank you very much. Thanks for the invite to talk today. So I guess now for something a little bit different. I'm a statistician, not a surgeon, and though I've worked with a lot of surgeons and in my past work for Cancer Research UK, where I was very proud to work with pancreas surgeons, and I work very closely with surgeons as part of ALGIS in the UK. So I lead a team of researchers at the Surgical Trial Centre in Leeds, at the University of Leeds, where I'm an NIHR research professor in statistics. And my methodological research, if I click on here, is that moving? No. Yeah, okay, that's working. My methodological research and my fellowship is looking at the statistical innovation and guidance on methods and analysis in surgery. So a project that we've called Sigma, and the overall aim of Sigma is the safe translation of surgical innovation into the NHS in the UK for patient benefit through improving the quality of surgical trials, so the statistical quality of the design of surgical trials. And the people on the screen are the brilliant people that are employed on my NIHR award. And we've got three main key areas of focus, which are addressing surgical experience and learning and how we incorporate that into research, the component parts of surgery and how we can better address that at the design and the analysis stage, and looking at the evidence generation pathway from first in human through to early phase trials through to the definitive phase 3 randomized trial that tends to change practice. And so as part of this research, we communicate with a lot of key stakeholders. I have them listed on this slide here, specifically surgical researchers who are in the green box through our NIHR in the UK, but also our Royal College of Surgeons and the International Ideal Group, and methodological researchers, including statisticians, of which I'm one, in the pink box. And so we have to do this really effectively as a team through our research discussions. We do a lot of teaching to be able to communicate statistical aspects of our clinical trial design and analysis. But predominantly, we have to do this really effectively in the development of new research studies, where our communication has to be especially effective to inform the right design. So what do we mean by communication? So I've gone straight to our Oxford University Dictionary, and the definition of good communication is the successful transmission of information. And in a research environment, I think this information falls into two key areas: conveying information around the input information, I've called it, for the design, robust design of studies to develop a robust plan. We often publish that in a protocol. And the second aspect is about conveying output of information, which is essentially in relation to data quality and analysis of data and communicating our analytical results, and often in relation to a planned publication. So conveying output of information is a real skill. This is Professor David Spiegelhalter, who has his most recent book. He's a prolific author, and his most recent book, which was published in 2020, I would really advise you to read. He's not only a brilliant statistician, but he's an absolutely brilliant communicator of statistics. So I definitely recommend reading this book, where he discusses data analysis and in particular data visualization for the appropriate interpretation, stating particularly that data literacy is the key skill for the modern world. So I've decided to focus on the conveying the input of information, because this is really what we do on a day-to-day basis at the Leeds Surgical Trial Centre. We communicate effectively for input information to develop robust statistical designs. It's a large part of what we do. I'm going to focus on another famous statistician here from some time ago, Sir Ronald Fisher, who famously highlighted the need for robust statistical design, and that clever statistics cannot rescue a badly designed study. So Fisher, for your information, I don't know whether you know, he was the person who developed the idea of randomization, which is a really important aspect of the design of randomized trials. He also introduced the idea of the threshold of the p-value being at the 5% level. And he also introduced the idea of conducting statistical modelling under the assumption of a lack of bias, which is a really important aspect of statistics. So most people, or lots of people, think that a lot of bias in research occurs at the data analysis stage and the data interpretation stage. Actually, in reality, the majority of statistical bias is introduced in research at the design and delivery stage of a trial. Hence the need for really effective communication to make sure we're getting the right research question, we understand the right research question, and that we have an aligned, robust statistical design. And I've just put on a slide here the types of bias in red that we're trying to minimize through the design and delivery of a surgical trial. So back to information. So I was trying to think about how to make this interesting today. And I think the most important aspect, the most frequent request of information that we get requested by surgeons is, what is the sample size of my study? That's the first thing that people want to know. So I'm not going to play this YouTube video because it's 3 minutes long, but I would recommend the links on the page. It's a YouTube video, 3 minutes long, demonstrating essentially very ineffective communication between a biologist and a statistician in attempt to try and agree a sample size. The communication is really ineffective because both parties fail to understand what information is required and why it's important. So the information doesn't get exchanged and the desired result, i.e. the sample size, is not achieved. It's not helped in this example by a really short timescale either. This highlights the really important aspect of timely communication as well as efficient communication and early engagement. So that's the information that surgeons want to be able to help you get that sample size. This is the information that is needed by statisticians, and in comparison, and probably quite annoying for the clinicians of you on the call, this feels like quite a lot of information to be able to get to be able to get to your sample size for robust study design. So again, just highlighting the need for early engagement to be able to really understand and communicate this information effectively. So some of the, I'm not going to go through all of these, but some of the types of questions that we might ask around this signposting of why, who, how, what, and when. These are the types of questions that we will ask to be able to retrieve the information that we need to be able to inform a robust study design and a subsequent sample size. So we need to understand the previous evidence to determine where the trial sits in the evidence generation pathway. And move my slide on. Yeah. And to understand also the specific patient population and what their usual standard of care is, what the anticipated outcomes of that specific eligibility patient group is, to be able to gauge what our clinically relevant difference might be to inform, that's needed to inform and justify a change in practice from a new intervention. And so we pull this information quite neatly together in a framework that we call PICO, that you may have heard about. So this is our population interventions, controls and outcomes. All of these aspects then we need to fully communicate and understand to be able to populate that PICO framework to be able to help develop a robust statistical plan. And statistical design is complex, but it is required to be able to get to a robust sample size. Essentially, a sample size, the sample size calculation is essentially the number of patients that we need to detect and evidence the difference between groups, if that difference really does exist. So essentially what we're powering is a statistical test. And the statistical test is specific to the underlying hypothesis, whether that's a non-inferiority trial or a superiority trial. It's very specific to the phase of study, whether that's early phase or late phase, whether it's a design is randomized or single arm or an adaptive trial. All of these things impact on our analysis plan, our statistical hypothesis testing, and that's then what we're powering and deriving our sample size to do. So this is the framework that we work to for surgical trials that differentiate the different hypotheses and the different outcomes that are relevant to progressive research phases. And in our scoping review of those earlier phase or early stage surgical trials, we've demonstrated that the statistical methods are much less well considered. So 2/3 of the studies in our review did not justify the sample size methods in the early phase trials. And this is one of the aims of the Sigma project. We also know that there are improvements that can be warranted in late phase randomized trials, specifically in relation to sample size. You can see on some of the arrows on the table here. And bias, but also highlighting the lack of consideration of surgical experience and the detail of the surgical intervention, which we know makes surgical trials different. So just a note on that, surgical trials are complex because surgeons are complex. We've got 4 surgeons on the graph here, blue, green, yellow and red. We know that as a new surgical intervention is introduced, that each of these surgeons will experience a period of learning, and the trajectory of that learning can differ depending on the surgical experience. This can have a significant impact on patient outcomes and hence our research outcomes, and is also a key consideration for us in the development of statistical methods in our Sigma project. We know that surgical trials are complex because surgery itself is a complex intervention due to the multiple component parts, as you can see on the screen here, in relation to preoperative site-level standards of care, actually what happens at the point of surgery, and that post-surgery recovery. And the combination of these different components can have a significant impact on patient outcomes. And again, is something we should consider in surgical trial design and is part of our Sigma project. So surgical trials are complex as we move through the research pathway. As you can see from the graph here, from early stage into late stage, you can see the variability that we experience is increasing in relation to our patient demographics, in relation to the types of interventions. And as we roll those out across sites, we see increasing complexity and variation in our controls and our standards of care. And understanding this variability statistically is a key consideration. Okay. So as always, any good clinical trial, including surgical trials, virtual trials, should be based on an important question, efficient designs, research should be deliverable and realistic, and should result in unbiased evidence. And so I'm just going to come back to the brilliant statistical communicator that is Professor David Spiegelhalter, who presents the problem-solving cycle requiring effective communication, essentially to firstly define the problem, then to plan the design and the data collection effectively, to effectively visualize the data, really important in modern day statistics, and to be able to best communicate and interpret the findings of any surgical research. I think essentially what we're saying is you need to come prepared to communicate. So I'll stop there and hope that ESSO may again invite me back to bring some of our findings of Sigma back to the group in the future. But thank you very much for your time and for the invite to talk today.
Well, thank you very much, Deborah. It was a very interesting talk. And I thank you for highlighting that surgeons are complex. That's always good to hear. We also think ourselves. And it's funny that in this HPB session, you showed the PPDEC, which is also, of course, for PDAC, for pancreatic ductal adenocarcinoma. So we feel very good in your hands.
We're very aligned.
Yeah, we're very aligned. So we'll come back after the second talk for questions to you. And I'm very happy to introduce Giovanni Marchegiani, who has called in from Verona. I think you're there, or maybe you're on the road again, because Giovanni is a very popular speaker. I know him quite well, and he's very active in the pancreatic research field and is involved in virtually all organizations working in pancreatic research and surgery. He's also involved in our ESSO-Pancreatic courses, and we have known him as a very informative and enthusiastic speaker. So we're very interested to hear your talk today, Giovanni.
Thank you, dear Sven, for the nice introduction and the kind invitation to you all. I was extremely happy to hear what has been said before, because I thought it was a very informative talk. Let me just open up the right window to share with you guys my presentation. Here we are. So I am currently now at a big conference in Portugal about pancreatic cancer. And guess what? I mean, all these issues in terms of collaboration, pitfalls, they all always come out. I don't know if it's a good way to overcome them, but I would like to propose you some solutions on how to overcome these issues by taking, of course, my field as an example. But I'm sure you can then apply the same principles, the same rules to all other fields of surgical oncology, at least. So let's start after this short introduction with, again, small examples. I love to repeat this whenever I give talk about the academic surgeons. At least probably it's very Italian, you know, to say that those who cannot, they teach, those who can, they operate, and those who truly know, they do research. Is something that I feel represent some aspects of my professional life. But I think this comes from a, let's say, old-fashioned sort of role of the surgeon. This is, I think, something that, I don't know, the generation before us was thought about, the surgeon being the one, you know, rushing and running among all the other figures that probably are now even more integrated in the modern pattern of medicine. But we'll see how this has changed. And again, I will use pancreatic cancer as an example. This is the bulk of literature published on pancreatic cancer over the last 50 years. And you can see that the survival of pancreatic cancer, unlike is usually thought, is actually increasing and has seen this increase in the last some 10, 20 years. If we go analyzing the reasons for this survival increase, well, the surgeons has to admit that it's not only surgical, but probably most likely is an oncological revolution. It's an oncologically driven revolution with new chemotherapy regimen, with a new multidisciplinary approach. So that's really an advancement in the field that we achieved together as a community. So I think this beautifully represents the shift into a new, different way of interacting among the specialists. The interplay now really puts the patient in the middle and put us all in circle, collaborating with each other for, of course, achieving better outcomes for our patients. And this is not only true in our hospital where we do work, it creates a network of such an interplay all over the world. After the pandemic, we are definitely more connected than ever. So I want to add probably another layer of complexity to this picture. However, this is not perfect. And there are some common pitfalls, I would say, along the way. I like to show this anytime I am into discussions with my colleagues. Are we really discussing into colleagues? Are we really into real discussion even within our own reality, our own center? Or are we, I'm talking about multidisciplinary meeting, for example, just running parallel monologues? You know, in Italy, we like to talk a lot, but are we really listening to each other? Are we calling the same things the same way? Well, the question is not so philosophical because even within our center, we have some conceptual gaps and even language barrier, even if we usually speak the same language among the same center. Look, for example, how we define a big pancreatic cancer involving the portal vein as this. So if I look at this with a surgeon's eye, I'm already planning an intervention to take the tumor out. Very big surgery. I would go for vascular resection and so on. Of course, in the eye of a pathologist, this is already something that needs to be staged in terms of TNM, lymph node status, and so on. A radiologist would describe that, right, in terms of, again, staging according to CT scan. But from other perspectives, such as the gastroenterological one and the oncologist one, I would say, main point would be even someone else. So how to overcome these usual pitfalls? Well, what we do in our center is really trying to promote some cross-training session. We have multiple meetings in person and online to try to promote this multidisciplinary discussion. And we do that trying to speak in the same language. I cannot underline enough how important it is to have a common glossary, a shared data dictionary, defining every single variable the same way. Sounds easy, but it's not. And when we try to overcome the same issue between different centers, we have something like a Tower of Babel when, for example, in my field, the definition of the major complication after pancreatic surgery, which is pancreatic fistula, before the year 2005 had more than 25 definitions. So can you imagine how these surgeons were able even to measure their outcome? How can they even try to do better by comparing these results if the definition was different? So standardize is the key. I am proudly part of this society aimed at standardizing all the complications in our surgeries. These are just some of the definition we provided, and that's the way to try to overcome these conceptual gaps among surgeons doing the same work. Second issue is about data and infrastructures. So I'll just give you again an example on how we try to have an active multicentric collaboration in Padova. And I'm very happy to see that this map is growing and growing with collaborations that are actually very, very important, and they remain strong by visiting each other and by having multiple online meetings. Why is that important? Because we have many important pitfalls. We all know that some data systems, they just collect data in a different way. We're now all becoming very expert in using Castor or RedCap, but this is actually not so easy to do. There is an issue with the quality of data control. There are, of course, also some ambiguity in data ownership, and I know that you are all aware of what I'm talking about. These are some of the possible solutions that something like ChatGPT provided to me. You can define yourself if you find them satisfactory or not. I find extremely meaningful a periodic data audit, which is something that I copied from our Dutch friends. I do many things the way the Dutch usually do, because I think that these really provide the knowledge and also the feeling of being part in a group, and not just someone who participates into a study or into a consortium by providing data, but also intellectually. I think this is very, very important. But we have other pitfalls, unfortunately. Third category of pitfalls is regarding the timing, the priorities, and the conflicting schedule. I really care about this slide, so please pay attention. This is how I think is a surgeon clinician, is like a square. Is a doctor with, of course, multiple skills. He or she is able to carry out a lot of very difficult operation. He is critically, of course, busy in monitoring his own or her own work. And in a way, this person is also an idealist, allowing for the appropriate time frame for all this activity. Very nice. I would love to be this squared surgeon clinician. But in reality, this is like a normal schedule of my day looks like. So while I am busy in the operating room, I would also have to attend all these meetings. And that's not only bad scheduling. Sometimes, you know, if you're a surgeon, that you cannot plan 100% all your activity. I, for example, I'm a surgical oncologist, but I work in a liver transplant surgeon as well. So, I mean, with all these cases coming in and then the emergency cases, sometimes that's how your plan look like. So it's very difficult to find protected time. Clinical urgency can clash with our scientific rigor. And of course, this has an impact in our clinical practice. So it is really an issue that we face every day. On the other hand, this is how a researcher look like. It's more a circle. So this person is someone creating new questions, finding answers, and indeed, eventually, creating new science. So this is actually very important because, of course, in this way, it's probably easier to set deadlines. Of course, it takes time to be rigorous on these, and we also need to find resources, you know, to do all these nice things. So how can we indeed, so to say, square the circle? How can we make these things coming together to create this modern concept of a surgeon clinician who is also a researcher? This is my recipe. Probably is not a perfect one, but it's very important, I think, to plan everything with the team. You're not alone. You have a team. Use it wisely. This is probably more to my Italian colleague. You have to be able to delegate. It's very, very important. You have a team for that. So you must do this at some point. To people, you build a trust. You need to design realistic milestones. You need to create protected research time, even though it's difficult. And you always need to have a transparent communication. Only in this, you can really balance how this can be achieved, and you can build the trust on the people you work with. Finally, last but not least, we also have some human, cultural, and relational barriers. These are some of the common pitfalls we, I think, all experience in our working condition. Of course, I mean, there can be differences among different countries, but you know, these are also a possible solution. It's obviously important to have a clear governance. We need to recognize everyone's contribution. Again, this is something that I learned again from my Dutch friends. I really like, for example, when in the presentation you show the picture of the PhD who is involved in the process. These are like small things, but they really make a difference in letting everyone feel part of a team. Rotating meeting leadership is absolutely important. Again, taught to me by the Dutch on how to run randomized control trial. I mean, I can run a given study, but then I can rotate leadership of another study into another center. And this is very, very important. What I learned from the Scandinavian is also to promote psychological safety by integrating psychologists who work closely with our team, able to understand when we can do better and in which situation. And also encouraging informal interaction. For Italian, of course, is having an espresso and discussing in front of an espresso, also with some Italian gesture, how we can do better. And this is very important because here comes the last part, probably one of the most painful one, ethical, regulatory, and financial barriers. So we know we all have to deal with ethical and regulatory approval, something that 10 years ago was probably not even existing, but very different. And now it's really, really painful. We know that we can have different ethics approval processes. We all deal with GDPR, national law, and it's actually very difficult. It's actually very difficult because it deserves a budget. And we know that there are a lot of paperwork to be done. It is so massive that I am aware that worldwide, this is now even provoking significant delays in research. And think about the US. I mean, this is sometimes even closing, shutting down some research programs. So this is something extremely painful, extremely dangerous that we all need to face. So I don't have, of course, a recipe on how to deal with this, but it's very important to bear in mind that this plays a role. You need to have people who are completely devoted to this to make it through. You need to anticipate the ethics timeline, and you must always anticipate that this will be an issue in your research. In other words, this is the only way to bridge the gap. The 5 areas that I found are basically the Death Valley of translational medicine, and only by bridging this, only by really creating what is a true multidisciplinary collaboration, bringing the research from bench to bedside, but also the clinical practice from the bedside to the bench, then we can really build fruitful and multidisciplinary collaboration. It's not just something that remains in the words. It's something that we all must do in our clinical practice, in our normal life, to get better together, to be better doctors. And the only one in the end benefiting from this approach are our patients. So this was my take on the topic. Again, thank you very much for having me. And I would love to have some debate about that, because of course, these are all very urgent questions that doesn't have probably an answer. Thank you very much again.
Well, thank you, Giovanni, for an excellent talk again. Very lively from Portugal. So very good that you could find the time for this very inspirational talk. And I do feel with your last point about the legal aspects that some of our PhD students have to become like a legal worker to go all through the painful process. How do you think you said about bridging the gap? And I want to encourage all the people who are in this call to put in questions in the chat, so we can ask them to the speakers, to Giovanni and Deborah. But how do you think, Giovanni, we can bridge the gap? Do you think it's necessary as a clinician surgeon to do research time to understand the language, or do we need other people who can bridge the gap? For instance, I'm also directing an education that is on clinical technologists, or say more technical doctors. Do you think that is a solution, or should we also invitate the researchers more into the clinical field so they can understand our life as well?
So Sven, thank you for this, for clarifying this point. Can I be a little bit brutal on this? Because otherwise it's all like very nice, wording, So we as surgeons, we have to be creative. We have to be creative in the OR. We have to be creative in research. And it's always good, to come out with solutions. And indeed, we really make the most out of our time to bridge this gap. But the real answer, in my eyes, is resources. We need to have resources. We need to have political decisions allowing us to do this. Because what you just underlined, is, of course, can be a temporary solution. But if I don't have the resources to bridge this gap, I can come out with a lot of nice solutions, but there needs to be someone, who is actually doing the job. We're making the examples of all the regulation when it comes to ethical. How can that be done by a PhD? Because ideally that is like his time or her time for research, rather than going through something which has more to do with laws or economical stuff. There needs to be resources at each hospital, to favor research instead of putting troubles, into those who has the idea. I think it's already, I would say, complicated enough, to come out with a research idea, to develop a methodological plan, then to allow, for the resources to come, indeed to analyze the result and to share them and to disseminate them. So, I mean, if really there is let's say the goal, the aim to promote the research, there needs to be political brave choices to provide us with resources to do that. Because again, we can be creative, but it's not enough.
Clear answer. And some convincing to do then to our hospital directors. So to bridge the gap between you and Deborah, how can we help the statisticians, you think? We are complex. How can we help Deborah? Because she said the main question that we come up with is the sample size.
She raised their hand, Deborah.
Okay. Sorry.
Let me tell you, Deborah, I enjoyed your talk a lot. I probably steal some of your slides because what I always say to my student is that I always see surgeons coming to the statistician with a very busy Excel and then asking for some p-values or other crazy requests. And this is like something that you should really avoid, like putting pineapple on a pizza. You really destroy my heart, okay, if you do that. Or if you like drink cappuccino in the afternoon, very forbidden. So you really want to stick to what the statistician can do for you. So first, my recipe would be to involve them since the very beginning, because even to come out with the right research idea, it comes from interaction with, for example, me and Deborah. And then designing that together. I mean, she would do anything out of my data if they come into a busy Excel file, if there is no planification since the very beginning together. Am I correct, Deborah, or am I wrong on this?
Yeah, absolutely. It's about working together. It's about, we're part of that multidisciplinary team, essentially, when you're developing your research proposal, because it can take months, coming, and we often get people coming with a sample, can you do me a sample size? I've got a grant going in, next week. It's not going to happen. We can't unpick that amount of information. We can put something, anyone can plug something in 5 minutes into a program and get a number. That doesn't mean that it's right, and it doesn't mean it's, it's robust. The sample size is the last bit of your study design. It's the very last bit. Giovanni, I've got some better slides. I've got more slides and better slides, so we can talk about that offline. The reason I put my hand up though was I think we're very lucky in the UK. I'm funded on a method. My fellowship is a methodological fellowship, but it's funded by essentially our Department of Health, our UK government, and those fellowships are predominantly clinical. I'm lucky to have a methodological one, but I'm, few and far between. A lot of the fellowship schemes that we have are for our clinicians, and so that does allow them to apply and to free up their time to be able to focus on really important questions that are important to patients, are going to impact our, current NHS. One of the barriers that we do here, though, is and I don't know what the answer to this is, but some of the surgeons are probably more the surgeons than other clinicians, often have an anxiety about coming out of surgical practice to do that research. And so that I think there is always that tension. We've developed in the UK a brilliant infrastructure and a funding infrastructure to be able to allow exactly what you're talking about to happen, and to allow people that research time and funded research time and that funded research space. But there is an anxiety about moving out of that surgical environment and keeping up with the surgical techniques and et cetera, for, a 5-year fellowship. So I just wanted to make that point. It wasn't really a question. I was making that point.
Right. If I may, I would have the next question, and that is about the team dynamics, because teams are composed of individual people with different backgrounds, expectations, personalities. It can also vary quite a lot when it comes across different countries and institutions. If you should highlight some kind of core principles, how to develop a good team and how to make it work when it comes to team dynamics, and also some very promising projects sometimes fall apart. What is your experience about that? Thank you.
I'll go first and Giovanni can answer. I think patience is really, you've got to acknowledge around the table that people have got very different skill sets and very different backgrounds and very different experiences. What you're trying to pull out of everybody around that table is that experience and those, you know, that skill that they have, that they brought to the table. And so listening to what people are saying is really important. You know, really listening to what the question is. If someone's asking you a question, really listen and answer that question. Don't answer something, you know, something differently. And also accept that the terminology and the language you're using may not be well understood by everybody around the table. You know, I'm older now, so I'm happy to call people out and say, what does that acronym mean? Please explain in words of 2 syllables what you've just said. I'm a methodologist, I'm a statistician, I'm not clinically trained, I'm not, you know, I'm not a surgeon. You've just said something to me and I haven't understood what you've just said because it's far too clinical. So I think, you know, making sure you're talking to your audience, talk to your audience, make sure that you can be well understood in what you're trying to say, but also listen to the questions that people are asking and make sure you answer those questions, would be my advice.
Giovanni, what would be your insights on this?
I would like to add, Dana, what you know very well, because we participated together into a postgraduate course where we all came with our different background and from also different areas, not only within the surgical oncologist. We were working closely with a statistician, but also with a psychologist who was able to let our interaction be really fruitful. And one of the most important points that was touched is really what Deb just said. Being able to listen and provide real answers is key. We try, of course, to bring, let's say, the statistician more into the clinical side. Not that I need you to scrub in into a surgical procedure, but to let you be aware what is important to me, what matters to my patient. And that goes way beyond a p-value, which doesn't mean anything. You teach me that to me. So, and at the same time, I should have some, let's say, basics of statistics, because you made the example of the sample size. We also know, if you have a little bit of experience, that this is also something you can play around with, of course, with cautious, but it's not that I want to, you know, define whether this is better than that. Sample size, 2 million patients, okay, study is gone. No, we need to sit again, asking question to you, how can we overcome this problem? And then coming together likely with a solution. The only problem, guys, it takes time and it takes effort. There is no easy way to do so. That's the only problem. In this TikTok society, we all look for very easy answer and we only have 20 seconds to overcome a problem. This is not gonna be done. I don't know if with the AI, maybe, I don't know. But so to date, correct me, Deb, if I'm wrong, this takes a lot of effort, a lot of years of study, and a lot of time, even with the human interaction. And sometimes our busy life provides us with wrong messages. This is not something that can be solved by scrolling our screen, you know, and get some video content. It takes efforts and time.
And to follow up on that, Giovanni, because I think that's an excellent point. How do we make sure that we, with our trials, really add clinical value? Because sometimes we're doing these trials for doing the trial. I sometimes got a feeling. So do you think that the statistician should play a more important role in that, sending sometimes the clinician back? Do you really want to do this trial because you're now looking for a 1% increase of whatever endpoint? Is that really gonna value our patient? Of course, I can make a composite endpoint to make it statistically significant. Do you feel comfortable with that, sending the clinicians back to the drawing table? And should we do it more often?
You teach me this, Sven, with all the consortium that you. No, really. I mean, in a good way. So you're right. You nailed it. It's a crucial point. So the thing is, I only see overcoming this issue by a constant interaction, because the clinicians know what matters for patients. At the same time, they have to demonstrate it, and the statistician knows how this can be possibly achieved, but at the same time is lacking the clinical counterpart again. So running interim analysis is a good solution, for example, to see where this is going. For example, I have in mind some negative trials which provided even more meaningful answers than positive ones, just by saying, listen, the question maybe was a good one, but the setting was wrong. And this is actually, telling us that you should not do this procedure because it's not safe in your hands for the patient, regardless of the outcome. So in my view, I hope I can define myself as a surgeon scientist, every research matters. Every research is important. But it's not true that every research must be published and that every research has a clinical impact. Doing research just per se might add a line in your CV, might add a line in your medline, but might not be of impact for our patients. And indeed, it won't change the clinical practice. I know it's difficult, Sven, because if we go back both to the first years of our career, that publication was really important, because having 7 or having 8 makes an impact. But then when you grow up, you understand that there needs to be something else. And that actually is very, very important. At the same time, we always need to sort of like support our younger colleagues. And we need to also keep this factor in mind. The people coming at us because they want to learn, they need to be nourished, they need to be respected. Also because we are all facing now a very big issue in surgery, which is in less and less people interested in doing our job. And that's not their fault. It's not Generation Z fault. It's our generation fault because we're not able to provide education. We're not able to make them love our job. And so that's another, I think, very, very important lesson that I am learning myself now by dealing with a lot of students, a lot of, university classes and things. And we must keep these very well in mind. Otherwise, in 5 years, it will be just me and you, Sven, in front of an espresso, but no one would listen to us.
And the robot will do all the work. That's also
exactly. Why not? Why not? Why not?
Yeah,
I think
it's a valid point.
Just
Deborah, the ending words are for you because our time is up.
I was just
please
gonna
give our
add,
final
yeah,
thoughts.
I was just going to add to that around the ethics. I think, that we shouldn't be doing research for research's sake. It has to be research that's going to benefit patients, that's important to patients, that patients have had input to. So we're measuring and making decisions on the right things that are sensible and important to them. There's an ethical aspect to recruiting patients into studies that are, not going to change practice because the clinical society don't believe it's the right question, or we're not answering it in the right way, we're collecting the wrong data, we're evidencing the wrong thing. So, ethically, then you're recruiting patients into that study, and if it's not quite right for the clinical community, then there's an ethical aspect there as well. So we would always have patients, validating the research questions. I think also we challenge our surgeons to say, okay, this is the single most important question to you, and we can develop the best grant application in the world and we can get that funded. But if everybody else in the country doesn't agree with you, they're not going to recruit to this trial. So, getting the grant is one thing, recruiting patients and delivering the grant is even harder. So we would always challenge our individual surgeons who come to us to design a study to pull in the national picture, to pull in their societies, to have that input to make sure that we are designing a study that is important to them, but is important to the rest of the clinical community, so that when we deliver, they'll recruit, but also when we deliver the trial in terms of data and results, we'll change practice. Because again, you can have the best New England Journal of Medicine paper in the world, it doesn't necessarily mean you're going to change practice. So I think that buy-in right at the beginning, what evidence do you need to say to change your practice on a national level, is what we challenge our individual surgeons with when they come with questions.
I would say amen. It's beautiful words and it really sums up my feeling as well. So I think everyone should have his own dep to go to and start, talking about this research out there and really shaping it, because I really think it's also a waste of time to spend a couple of years on a trial which will not be implemented. So with that said, I would like to thank you, Deborah and Giovanni, very much on behalf of the ESSO and the CSO. I think it's been a very insightful webinar. First hour we talked about artificial intelligence, and the next hour about bridging the gap between statisticians and surgical oncologists. I would like to thank all in the meeting and hope to see you in the future on behalf of Dana as well.
Thank you very much,
Thank
guys,
you.
for having us.
Thanks to
Have a
you.
good day.
Bye-bye.
Bye-bye.
Thank you.
Thank
Bye.
you for the
very much.
invite. Bye.